Give it 1 second.
Sure.
All right, and we're live.
Okay. Welcome to the Health and Government Operations Committee, everybody. It's good to see you all here. Please don't forward the Zoom link for the hearings. Staff will not allow anyone who is not invited to testify into the hearing. I ask you to encourage people to watch the hearing on YouTube. Bill sponsor witness timing. The sponsor is allotted, or designee is allotted 5 minutes to present the bill. 5 witnesses will be allowed each to speak for 2 minutes in support. Please stay in the hearing until the delegates have had the opportunity to ask questions. Then the next 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you hear, oh, there's no timer ring. Please conclude your remarks when you see the time ending on your screen because it's a shared screen and it's big print and hopefully you will see that. Members must remain present with your video camera on during the entirety of the hearing. Members, please remember to ask only one question of one witness. If you have other questions, you may follow up offline. Please use the raised hand function to indicate that you have a question. And with that, the first bill on the hearing, and I'm sorry I didn't pull up the witness list yet, but I will. Looks like it's Delegate Ivy, and there are no witnesses. Delegate Ivy.
Thank you, Madam Chair. Colleagues, for the record, Delegate Julian Ivy here presenting House Bill 162. Under state law, the Prescription Drug Affordability Board must make specific determinations, collect data, and it may conduct cost reviews of each identified prescription drug. If the board finds that it is in the best interest of the state, it may draft a plan of action to set upper payment limits on certain prescription drug products that may cause affordability issues. This legislation, as introduced, repeals the requirement that the board find that it's in the best interest of the state before it may submit a plan of action to set upper payment limits on certain prescription drug products. As introduced, House Bill 162 would require that the board must, rather than may, set upper payment limits by February 1st, 2022. First, I'd like to thank and commend Vice Chair Pena-Melnick and this entire committee for sponsoring and passing House Bill 768 in 2019. Which established the Prescription Drug Affordability Board, the first of its kind in the U.S. House Bill 162 is introduced, mirrors some provisions that were amended out of the original text of House Bill 768. This piece of legislation seeks to build on our momentum in the fight against the rising cost of prescription drug prices. In the midst of a public health pandemic and an economic crisis, it's extremely important that we work quickly to lower the cost of prescription drug prices in our state. As a result of COVID-19, too many families in Maryland are financially overwhelmed and stretched to their limits. Any savings on the cost of their life-saving prescription drugs will bring much needed relief for Marylanders. I'm asking for a favorable report on House Bill 162. Thank you.
You're welcome. Let me pull up my bar to see if we have any questions. Delegate Kipke.
Thank you, Madam Chairman. Hello, Delegate, and welcome to our committee. It's good to see you.
Nice to see you, sir.
What I'm curious about is if the board thinks it's not in the best interest of the state, why would we want to do anything?
Well, I don't think that it would be in the best interest of the state to allow for prescription drug prices to be higher than they absolutely have to be. And so that was the origination of the genesis of this bill, this piece of legislation, to require that they set these limits. This doesn't say what those limits, those upper limits should be, just that they are established.
Okay, so what if throughout their work, they determine that there's a better process for controlling the cost of pharmaceuticals and other treatments?
I think that that would be a wonderful discovery for them. However, this piece of legislation, it says that by February 1st, 2022, that upper payment limits would be set. And I think that is important that we establish those upper payment limits.
Okay, thank you.
Thank you, sir.
Seeing no other questions, that ends the hearing on House Bill 162. Thank you very much, Delegate, for being here. It was a pleasure to have you today.
Always a pleasure.
The next bill is House Bill 14, Delegate Kerr.
Okay, I'm unmuted. Good afternoon, Chairman Pendergrass, members of Health and Government Operations. I'm Delegate Ken Kerr presenting House Bill 14, Pharmacist, Prescription Drug, and Device Labeling Expiration Dates. This bill specifies that drugs dispensed by a pharmacist in the manufacturer's original packaging may use the manufacturer's expiration date included on the label or a shorter period as determined by the pharmacist. This applies only to medications in the sealed original manufacturer's packaging. Currently, since a law was passed in 1979, drug manufacturers are required to stamp an expiration date on their products. This expiration date is the final date that the manufacturer guarantees full potency and safety of the medication. However, a study conducted by the Food and Drug Administration in 1985 at the request of the military found that 90% of prescriptions assayed were good even 15 years after the manufacturer's expiration date. And while this bill doesn't suggest that people take drugs past the manufacturer's expiry date, even though FDA evidence suggests that would probably be okay, the bill asks that pharmacists be permitted to use the manufacturer's expiry date as opposed to current law, which specifies they must put an expiration date 1 year from the date that the drug was dispensed. So let me give you an example. Here's a medication that I take every day, and you can see that the manufacturer's date is on the label here, but then the pharmacist has put a date there that it was filled on December 11th, 2020, so it expires on December 11th, 2021. You can see that's still in the manufacturer's sealed container. Now I have another one here, same prescription filled on the 11th, expiring a year later. However, this manufacturer's date is February 2023, a full year and then some after the pharmacist's expiration date. So another interesting factor is that when you get a 90-day supply, so a 90-day supply, they give me 3 of these with 30 doses in each bottle. You can refill it, a 90-day supply, 21 days before your 90 days is up. So over time, you end up with an extra bottle. So what happens if I reach in and I grab the a newer bottle, and this one that has the 2023 expiration date gets shuffled to the back, and it's after December 11th, 2021, normally I would have to throw this out or be encouraged to throw this out. So you can see that allowing the pharmacist to designate the manufacturer's expiration date rather than the current state law mandated 1 year from the date of dispensing would keep the cost of prescription drugs down and more affordable for Marylanders. So I'd like you now to hear from my sponsor panel. I have Brian Lowe of Walgreens and Sarah Price of the Maryland Retailers Association, and after which we'd be happy to answer any of your questions.
Brian Lowe, you're up.
Thank you. Thank you, Chairman. Good afternoon. Thank you for the opportunity to testify on House Bill 14 today. Again, my name is Brian Lowe. I'm the Regional Director of State and Local Government Relations for Walgreens. Walgreens is supportive of House Bill 14, which would change state law to allow pharmacists to use an expiration date on prescription labels to be equal to the manufacturer's expiration date. Many prescription medications are dispensed in the original manufacturer packaging, such as an inhaler, oral contraceptives, high-dollar specialty medication, and these medications have expiration dates printed on the package from the manufacturer, as Delegate Kerr just showed us. Existing state law requires pharmacists to print on the label that the medication expires no more than 1 year from the date of dispensing, even though the manufacturer's expiration date on the package can be 1 or more years after that 1 year required expiration date. This can lead to patients throwing out and replacing medication prior to the expiration date of the manufacturer. The benefit to patients in House Bill 14 is that the patient doesn't have to replace these costly medications prior to the expiration date set by the manufacturer. Is it right to ask patients to discard prescription medications that still have shelf life past the state required 1 year expiration date? Walgreens received a number of consumer complaints in the early to mid 2000s regarding prescription labels with expiration dates conflicting with the manufacturer's expiration date. At that time, Walgreens changed our policy to use the manufacturer's expiration date on prescriptions dispensed in the manufacturer's original packaging. Although this change went into effect over 15 years ago, Walgreens had not been cited for any violations until 2018. Since 2018, the Maryland Board of Pharmacy has cited Walgreens over 50 times for following the manufacturer's expiration date. Walgreens is requesting your support of House Bill 14 to help limit healthcare costs by allowing pharmacists to utilize the manufacturer's expiration date, which will help limit patients from discarding viable product. I'd be happy to answer any questions that you may have. Thank you.
Let's have Sarah Price next, and then we'll have questions.
Hi, thank you. Good afternoon, Chair Pendergrass and honorable members of the committee. My name is Sarah Price, and I'm here for the Maryland Association of Chain Drugstores, which is managed by the Maryland Retailers Association. First of all, I would like to thank Delegate Kerr for working with us on this legislation. As you are all aware, it has not been easy to put bills together while we're all virtual, and we really appreciate his support on this bill. As you have heard from my colleague in the industry, the current Maryland law regarding expiration dates has resulted in consumer rights issues and fines for pharmacies. So HB 14 is a very simple, common sense pharmacy bill that would help to clear up consumer confusion and reduce unnecessary waste by allowing pharmacists to utilize the manufacturer printed expiration date. Thank you for your consideration, and we would urge a favorable report on the bill.
Thank you. Delegate Kelly, followed by Delegate Hill.
Thank you, Madam Chairman, and thank you for this bill, Delegate Kerr. I don't know who is best to answer this question, but it's a two-part question. The first is just the Department of Health is suggesting what they call a technical amendment, adding the word sealed to manufacturers' packaging, and I'd like to know if you guys are okay with that. And also, bigger picture question, aside from increasing our drug spend, what was the purpose of the original, why did we put this into law? Does anybody know? I know you're the proponents of the bill, but I would just be curious if you could explain to me. Probably it's something that's outdated would be my guess. But
Perhaps Brian Lowe is best to answer that one.
Yeah, for your first question on the sealed manufacturing, I think that would be something that we would be agreeable to, at least from Walgreens. As to why this was built into state law in the past, I don't have an answer for that. I'm fairly new to Walgreens. It was not around at that time. Like I said, it's in state law for a number of years now, though. So I would defer to anybody else that may know.
it's not important. Thank you very much.
Sorry.
Delegate Hill.
Thank you, Madam Chair. And Delegate Kerr, thank you. This is a great bill, and it's one that's been in my back pocket, and I wasn't getting to it. I'm so glad you did this because, and here's the question. I did not know that Walgreens or other pharmacists were actually being fined for this. I'd like to know how much money they have had to fork over since 2018 given that what our law essentially does is tell them to lie to their patients, their customers, by lying about what the actual manufacturer expiration date is. So I'm really curious about that and whether there was any legal action taken about the, I would call it unconstitutional nature of whatever law we put into place that required them to lie to their patients.
Thank you, Delegate Hill.
Whoever would like to answer.
I can take this one.
Go ahead.
Like I said, we've been fined a number of times. I don't have the exact number that we've been fined, but it's in the tens of thousands of dollars since 2018. I would say north of 50,000.
All right. Would you be able to just get the committee that information?
I can certainly do that.
Not sure we can do anything about it because the department was required to do what they were required to do, but.
Yeah, and to answer your question on legal action, that's not something that we had, I've heard about. I don't think it's something that we're interested in. We're just looking for the change in existing.
All right, thank you. This is very good bill. Thank you. And to Delegate Kelly.
Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for bringing this issue to us. Delegate Kerr, not just saving Marylanders money, but would this help, in your opinion, the environment where people were not flushing as many pills down the toilet to get into our waterways or having to incinerate medications that have been discarded?
That's a good point. And it leads me to another point that didn't come out in my testimony. It just wasn't sure that it was relevant, but just the Air Force alone was saving $800,000 a year and not having to discard outdated medication. And as I said, that's not what this bill intends to do. It just speaks to the level of safety there is in allowing the manufacturer's date to be used, because in 90% of the cases, these medications are potent and safe up to sometimes decades beyond their expiration date. But yes, Delegate Johnson, it would help the environment with unnecessary disposal prior to use.
Thank you.
Delegate Krebs.
Thank you, Madam Chair. And I echo what's been said before me about the interesting to know what the history of this bill is and how it took so long to get it changed. But I was wondering if you would entertain a motion or if it would help to make this emergency legislation, or do you believe that the Board of Pharmacists, if we passed it, would just stop enforcing it? Because we'd like to see it probably in effect as soon as possible.
Delegate Krebs, I guess I don't have an opinion on that. I hadn't considered emergency legislation. The advocates and I certainly would not be opposed to that.
It just seems
Let's suggest that Delegate Kelly, via her subcommittee role. Oh, is it Delegate Kelly? This is yours. Yes. Or is it Cullison?
It would be Delegate Cullison.
Delegate Cullison, I'm going to ask you in your role as subcommittee chair if you would be in touch with the department or with the boards or whoever and make sure, because that's a good thought. And I think that there's pretty much agreement on this bill.
Thank you,
Madam Chair. Will do.
Thank you. That's the end of questions. Delegate Kerr, nice job. Thank you for the bill. And that ends the hearing on House Bill 14. I'm going to ask that we not make speeches when we ask questions. It's multiple times. It's not a single person. It's multiple people. I would request that we just ask our question and get our answer, as opposed to a speech before the question, a speech after the question. This is a time for witnesses to speak. Thank you. We'll now turn to, that did end the hearing on House Bill 14. We'll now turn to House Bill 107. Delegate Robin Lewis.
Thank you, Madam Chair. I'll wait for my countdown signal. Thank you so much. For the record, Delegate Robin Lewis, here on behalf of House Bill 107. This bill proposes to repeal a prohibition on selling over-the-counter medications in vending machines. And you're probably wondering why vending machines Why over-the-counter medications? I see this proposal as a COVID response. One of the challenges we've all witnessed during the pandemic are the cracks in the foundation of our healthcare system, obstacles to healthcare access, whether it's health services or medications. Those obstacles make it harder for people to stay safe and get well during the pandemic. By making over-the-counter medications available in vending machines in the state of Maryland, we break one of those barriers to accessing much needed everyday over-the-counter products. In Maryland, we've already enabled access to analgesics in vending machines. We also regulations that permit the sale of condoms in vending machines. But what we don't have is the ability to make available in communities that have low concentration of pharmacy outlets. We don't have the ability to make it easy for vulnerable people to access things like gastric remedies like Pepto-Bismol or Band-Aids or other products that people need on an everyday basis and can be hard to get. Vending machines are simple and effective low-cost way to dispense medications. Maryland is one of just 4 states that does not allow over-the-counter products to be sold there. So I think I'll wind up by saying that as we're working to adapt to the pandemic, let's work together to reduce obstacles to healthcare access. Low-hanging fruit here. And I really hope that my colleagues will see this as an easy win for health equity. I request a favorable report. Madam Chair, I'd like to ask my panelists in this order, if I may. If you please, Robin Elliott first, then Dr. Susan Wood, and finally Ashley Black. Thank you.
You can accommodate that, Delegate. Thank you for the information. We'll start with Robin Elliott.
All right.
Robin, are you there?
I'm there. Can you see me and hear me?
Yes.
We can.
All right. Good afternoon. Thank you so much. I'm actually here today as a policy researcher. Over the summer, one of my COVID projects was to look with colleagues at the National Health Law Program at all 50 states in the District of Columbia and their vending machine rules. So you have in your packet, and I'll just show you because it took me so many hours to do, but you'll see this map that shows vending machine laws in other states. And as Delegate Lewis said, Maryland's one of just 4 states with restrictions. Those other states along with us are Connecticut, Georgia, and Oklahoma. So 4 states that usually don't have much in common. I'll just flag that we know that these rules are so old that we couldn't actually figure out where they came from. There's no legislative record. And so it seems, given all that's going on and many of the issues that Delegate Lewis raised, and you'll hear from other panels, that the most simplest solution would be to repeal Maryland's prohibition against the sale of over-the-counter medications in vending machines. Thank you.
Thank you. We'll now turn to Susan Wood. Susan Wood, are you there?
She should be in the meeting, yes.
Okay. Susan Wood, you're up.
Yes, I'm here. Sorry. Can you hear me?
Yes, thank you.
Yes. Thank you. And I appreciate the opportunity to be able to testify today. My name is Susan Wood, and I'm a professor of health policy and management at the George Washington University School of Public Health and Health Services. In addition, for 5 years, I was an assistant commissioner at the FDA, where I directed the Office of Women's Health. And so I'm here to provide some perspective on FDA regulation of over-the-counter medicines and vending machines. So as you know, FDA regulates medications that are to be marketed in the US, and they are either designated prescription or non-prescription, which is also called OTC, over-the-counter. And there's a difference between the two. Prescription requires the engagement of a health professional or learned intermediary. Whereas over-the-counter medications also have to be safe and effective, and they're often more safe than prescription medications. And consumers have to be able to self-diagnose, self-treat, and self-manage without that learned intermediary. And so as mentioned, things for headaches, indigestion, some infections, all sorts of over-the-counter medications exist. And their studies have to have been submitted and approved by FDA to show that the consumer can understand it and actually use them correctly, and based solely on the product labeling, which is really important. So once a product is approved as a non-prescription drug, it can be sold in a variety of settings. Grocery stores, gas stations, and vending machines. And there's nothing in FDA statute or regulation that would limit the sale of over-the-counter medications in vending machines or in places other than pharmacies. And indeed, in their FDA compliance policy guide, this is stated, and it indicates that as long as the products meet the labeling requirements, FDA does not restrict vending machines as a point of sale for over-the-counter medications. So based on that information, I strongly support this legislation, and particularly when you combine it with the study by Robin Elliott, that this legislation would improve access to consumers to key and very important medications in vending machines. Thank you.
Thank you. We'll now hear from Ashley Black.
Okay, can you see and hear me?
Yes. Thank you.
Wonderful. Good afternoon. My name is Ashley Black. I lead the Public Justice Center's Health Rights Project. We support policies and practices that promote overall health of Marylanders struggling to make ends meet, with the explicit goal of promoting strategies that work to eliminate racial and ethnic disparities in health outcomes. We strongly support this bill, which is really about timely and convenient access to healthcare for consumers. We can ensure that Marylanders do not have to travel or wait for a pharmacy to open to get access to what they need. This bill takes into consideration that many people do not live near a 24-hour pharmacy that sells over-the-counter medications. And in Maryland, there are pharmacy deserts in communities with higher populations of low-income individuals and people of color. Similarly, due to COVID-19 pandemic, many of the people who are sick or having health complications that are managed with physician-recommended over-the-counter medications are trying to avoid public spaces. So this bill not only supports social distancing, but there's also research that shows that vending machines stocked with over-the-counter medications increase patient adherence to medication, and as a result can actually lower healthcare costs because it's reducing return visits to doctor's offices and hospital admissions. Finally, these vending machines have the impact of empowering communities to negotiate affordable prices with manufacturers and negotiating what's stocked in their vending machines so that the service is responsive not only to community need, but to the average income level of that community. It's time for Maryland to join the rest of the country in eliminating inequities in pharmacy access. And thank you, and we urge a favorable report from the committee on this bill.
Thank you. I'm looking for hands to see if there are questions of this panel. Delegate Hill.
Thank you. So you mentioned the cost, and I remember when we could get aspirin in a vending machine. So you're saying the cost, that there's nothing additional that needs to be put in this to make sure that those vending machines in those pharmacy islands aren't gouging people? So can you explain it again to me how we can do this? And I know we don't
Thank you. Thank you, Delegate Hill. That's a good question. And Madam Chair, I'd like to direct it to someone best prepared to answer, whichever of my panelists feels they can best answer.
I think that's a
Does
question
either
for
one
Rob.
of you feel able to answer this?
Delegate Lewis, would you like to answer?
Yeah, whoever is best positioned, please.
Okay, thank you. So as Ashley Black just said, that communities who work to get these vending machines are empowered to negotiate those prices. What we have heard from some of our colleagues in other states, that the prices tend to be lower than what is offered in retail. Or they could be the same, but because the community is able to invest in a vending machine because it's not very much money, it's not the same as starting a store, they really can be in control of those negotiations. So I think it's a really good question, and wanted to thank Ms. Black for giving that specific example.
Okay. Delegate Johnson.
Thank you, Madam Chair. And thank you, Delegate Lewis and panel. Whoever's best suited to answer this question, would the Sudafed products be prohibited in vending machines?
Hello. Yes, I'm happy to answer that one. Sudafed is regulated by the DEA, the Drug Enforcement Agency, because of concerns of being diverted into illegal drug use and abuse. And so it is regulated, sort of on top of FDA regulation, and those regulations would still apply. So Sudafed is not available in general, it is OTC, but it has to then be checked for amounts purchased and doses and so forth, and tracked. And that's a separate DEA requirement. So it would not be available in vending machines due to those additional regulatory requirements.
Thank you. Thank you, Madam Chair.
Delegate Shalega.
Thank you, Madam Chair. We do have some opposition testimony that asks about an abortion-inducing drug like
Mifepristone.
Sorry.
Mifepristone.
Yes, clearly I'm not a pharmacist. Is that a prescription drug, or what can you tell me? Would this drug be available in the vending machine?
I think Dr. Wood, if you would kindly respond.
Yes, mifepristone is a prescription product at this point, and would not be available in a vending machine. It absolutely would not be available in a vending machine. Only over-the-counter products that are approved by FDA for non-prescription status would be eligible to be included.
And there was a testimony with some amendments. Are you guys where it's like the Brady Bunch, isn't it? It's hard to find your face. Where are you, Delegate Lewis? There you are.
I'm here. I'm here.
I feel like I need to look at you. Are you okay with the amendments that have been suggested?
Thank you so much. I think and you're referring to amendments offered by the Office of the Attorney General?
Yes, those are the ones.
Thank you. It's just for my clarification, is that a written letter or is that in-person testimony?
It's written.
Okay.
Yeah.
Thank you. So what I would say is this: I've had quite a few long conversations with representatives from the AG's office, and I understand their ideas and their suggestions, and I'm very much open to further conversation to consider how best to address concerns that they've raised. I consider their amendment friendly, but for the context of our hearing today, I can just say I'm willing to keep talking.
Okay, yeah, it seems like they're just trying to narrow it down to make sure it is non-prescription drugs. And then it sounds like ultimately the Department of Health will maintain some.
Okay. We've gone off the path of a question and an answer. I'm going to suggest that this is going to go to subcommittee, and that's where this kind of discussion will occur, as in discussion versus a question and an answer. I thank you for your question, Delegate Chalega, but I think we got the answer. Okay. There's no other questions listed in my panel. So that ends the hearing, knowing that it's going to subcommittee, and we'll get a thorough study. The hearing on House Bill 107 is finished, and we will move on to House Bill 34, and that's Delegate Rosenberg.
Thank you, Madam Chair and members of the House Bill 34 would build upon the essential step that we took during the regular session last year to provide for telehealth. No doubt, HIPAA aside, virtually everybody on this committee has personal experience with telehealth during the last 9 months, as do many, many of our constituents. But under existing law, students who are benefiting from student health, school-based health centers cannot take advantage of telehealth services from those facilities. And this bill would correct that. It is an emergency bill demonstrating the essential nature, the imperative of addressing this problem. It would also provide, it is in the bill itself is uncodified because it is requiring that this be done by Maryland Department of Health and State Department of Education, and explicitly says, the bill explicitly says that those two entities may not require an application to provide telehealth services from school-based health centers, nor may they establish regulations inconsistent with the standards in the law for all other telehealth providers. So this bill would keep us on the path that we started down last year. There is other telehealth legislation that will be before the committee this session, and we will consider that in due course. Also, in light of some of the opposition that has been offered to this bill, I would point out that the Medicaid covers overwhelmingly, if not entirely, the services that are provided by school-based health centers, and that because concerns have been raised about abortions at these facilities, and our Medicaid language in the budget every year is the standard for when these services can be provided. When that particular health care can be provided, that is abortion, by any facility being reimbursed by Medicaid. So there is no need to address that in this bill. I would move a favorable on the bill and appreciate your consideration, favorable consideration. Thank you.
With that, we'll move to the witnesses. We'll start with John Woolhams, then Robin Elliott, and then Joy Tuisigi, unless there's a different plan.
So John hasn't joined us in the Zoom room. I've sent him the link several times.
Then let's move on to Robin Elliott, shall we?
Great.
Thank you.
Great. So good afternoon again. Robin Elliott. I'm here today on behalf of the Maryland Assembly on School-Based Health Care. So in essence, we want to make sure that all school-based health centers are able to pivot to telehealth when they need to. And certainly under the current circumstances, we think that all school-based health centers should be doing telehealth. Right now, there are 86 school-based health centers. Only about 18 of them have been approved to provide telehealth services. So that means dozens and dozens of school-based health centers across Maryland are closed. And so this bill is really to eliminate an unnecessary barrier you all passed legislation, I'm sure you remember well, it was actually Delegate Rosenberg's bill that set uniform standards across all different healthcare practitioners and facilities about how to implement telehealth. So the MSDE process that they require is simply no longer necessary. So what the bill does is it asks MSDE to lift that process, and it's emergency legislation, as Delegate Rosenberg said, so that we can get it done as soon as the bill passes. Thank you so much.
Thank you. Is Joy here?
Yes.
Would you like to go next, Joy? And you could
Sure.
pronounce your name for me to help me, because I'm sorry I fumbled it.
Oh, it's totally fine. Joy Twessage.
Oh, I didn't do badly.
No, A+. So my name is Joy Twessage, and I'm the board chair of the Maryland Assembly on School-Based Healthcare, otherwise known as MASBC. I'm a nurse practitioner and Baltimore City resident and proud parent of a first grader at Medfield Heights. So by design, school-based health centers are located in schools with high concentrations of poverty, and we act as a safety net provider. So we're talking about kids who are homeless, uninsured, underinsured youth, youth without a medical home. And we establish care relationships, just like you do with your providers. And the reason we support this bill is because we want to continue our care relationships, meaning that we want to deliver care to students who are not physically present in school, whether the school building is open or not. So we want to be able to provide asthma management, obesity management, nutrition counseling, behavioral health, whether there's a pandemic or not. And this is already a routine part of clinical care. So from where we sit, this is easy to support. There are already established uniform requirements for telehealth across all types of healthcare practitioners under the health occupations boards. And all school-based health centers report visit information to any required federal and state agency, including the Maryland State Department of Education. Telemedicine is already being provided in schools with community-based behavioral health providers. And we've already built this infrastructure to ensure that youth don't fall through the cracks. And we ask that you help us to keep that commitment through changing circumstances. Thank you.
Thank you. We're going to give John Woolhams a chance to testify again if he is signed in now. Has he shown up?
So he messaged me and he's testifying in EHE. So unfortunately, he won't be able to join us today.
Okay, thank you for that. This happens. There are a lot of glitches. We're going to start our questions with Delegate Cullison.
Oh, thank you, Madam Chair. And I think Dr. I should know how to say your name, Joy, Dr. Joy. You hit on it, but can you just like expound a little bit on the health care equity issue that's presented by the fact that, 70% of the school-based health centers haven't been able to deliver service during the pandemic?
Absolutely. So, many of the pediatric offices, including FQHCs, have been overwhelmed. They're not able to see students, and these students, and additionally, so the issue of why can't the students just go someplace else when school-based health centers are closed is because the other clinics are at capacity themselves already, or there's actually just no other place for them to go across the state. That is definitely an issue, especially again with children who are homeless, children who are undocumented. There's no other place for these students to go, and so they're not getting health care at all. So it's definitely an equity issue for these students where they had care and now they don't have any care. They don't have continuity of care.
Thank you.
Thank you. I think that we have 3 members from another committee. Unfortunately, it wasn't in my notes where I was hoping to find it. I see that Delegate Julie Palkovich-Carr is in here. Unfortunately, I'm not sure who the other 2 people are. Is there anyone waiting in the waiting room?
No,
Melissa?
we have Delegate Hartman and Delegate Dana Jones as well.
Okay, somehow I just don't see them. What we do in our committee to the visiting members, welcome, thank you for being here, is we put up our little hand in reaction if you have a question to ask, and certainly you are welcome to ask questions if you have them. I see Delegate Krebs has a question. We'll take that next. And if any of the visitors who are jointly assigned to this bill as well from Ways and Means have questions, please feel free to raise your hands and feel like equal partners in this, please. Delegate Krebs.
Thank you, Madam Chair. I was reading the Department of Health's bill testimony, and I'm trying to understand. It says the school-based health clinics must adhere to federal Medicaid regulations regarding governing clinics. And under normal circumstances, Medicaid may not reimburse or other clinics if the practitioner is not physically located within the clinic. And then it says that because of the pandemic, the public health emergency, they've received permission to waive the four walls rule. So would this bill apply after the pandemic and after the state of emergency goes off forever? And would it still be aligned with the Medicaid rules?
Yes. Delegate Rosenberg, would you like me to answer that question?
Certainly. Go ahead.
Great. So that's a great question, Delegate Krebs. So there are two issues with telehealth and how it's set up. One is where the patient is, and the other is where the provider is. So right now, the idea that this four-wall rule has been waived means that both the patient and the provider can be other than the school-based health center. When the pandemic is over, telehealth is still relevant for the school-based health center as long as the practitioner, Dr. Joy, is in her office at the school-based health center, and the patient, the student, is homesick for whatever reason. Medicaid will reimburse for that. So it is still very relevant. And the first thing we need to do, though, is to make sure all school-based health centers are permitted to do telehealth by MSDE.
Thank you for explaining that.
Delegate Kelly.
Thank you, Madam Chairman. And my question is also for Dr. Joy. It's related to something you said at the very end of your answer to Delegate Cullison about the importance of continuity of care. I know I grew up without a medical home, and my anxiety around seeing new providers is very high. Would you say that the patients and the students that you're working with are particularly in need of that continuity of care?
They're absolutely in need of continuity of care. It takes a long time to build trust with these students, given their history, and so not only do you have the trust of the students, but you have the trust of the parents, and you're also helping them navigate, situations. So even if it's what seems as simple as asthma medication, that can actually be a huge ordeal when the formulary changes on Medicaid, or maybe you're as the nurse practitioner in the clinic, you're the one who's filling out paperwork so that they can get, free or lower reduced cost inhalers. So that connection that students have with the provider is really important. And especially when students are feeling isolated, whether it's they're at home or under stress because parents have lost their jobs, they have somebody that they have a relationship with that they can connect with and talk to about it.
Thank you.
I have a question for whoever is best able to answer this. I presume that the ability of doctors to practice medicine would be the same whether the doctor was located in the school office or in an office that was in the doctor's home, that the scope wouldn't change, that it would be the same things that you're now allowed to do. Would one of you confirm that that is accurate, please?
Absolutely. The scope of practice stays the same. Clinical guidelines, recommendations stay the same. It's just the location.
Okay. Okay. I see no other questions. So with that, John Willems has not gotten here still. He's still over in the Senate.
Yeah.
Okay. That ends the hearing on House Bill 34. And we will now move on to House Bill 191, Delegate Kelly.
Thank you, Madam Chairman and members of the committee. House Bill 191, which is entitled Maryland Medical Assistance Program, Psychiatrist and Psychiatric Nurse Practitioner Telemedicine Reimbursement, Sunset Termination. Mouthful of a title, but a really nice bill. I hope you guys like it as much as I do. This is a bill that is meant to remove a sunset from a program in behavioral health that is working really well. You should see in the fiscal note that MDH, the Department of Health, intends to make this program permanent, and they don't expect a fiscal impact. If you go back to way back to 2018, when we didn't know as much about telehealth, we passed legislation to allow prescribers on what are called ACT teams to use telehealth. But we put this sunset on because back then we wanted to check in to see if it all worked with this model of care. And as I'm mentioning, it works really well. You'll hear from the panel about that. Just to remind the committee what an ACT team is, obviously the providers will explain in more detail, but basically it's an assertive community treatment approach to serving the most vulnerable populations we have here in Maryland. So they could be people who are experiencing homelessness with somatic comorbidities and substance use disorders who also need psychiatric treatment. An ACT team always consists of a prescriber. It could be a psychiatric nurse practitioner, it could be a psychiatrist, but also social workers, substance use disorder professionals, employment specialists. They work within the community serving people who can't access care in traditional settings. That this bill is really simple, but also very important. There's a lot of people who are not going to testify today, but are supporting this. You'll see in the file, the Society of Addiction Medicine, NAMI, Mental Health Association of Maryland, the Rural Health Association of Maryland, and the Rural Maryland Council. Just want to note, ACT teams work in my very urban district in Bethesda, also work rural across the state. People are benefiting from this. The Hospital Association supports, MedChi supports, Do the Most Good supports. I did want to note that you'll see that there is a support with amendment that asks that we expand this legislation to include the audio-only telehealth. I want to remind the committee we're going to hear that bill separately. Very important conversation also, but I think it would be really efficient to just pass this simple bill that removes the sunset because what the ACT teams are doing is incredibly important work. And I am going to urge a favorable report and pass the rest of my time off to Lori Doyle so she and the providers she has brought can really talk about the great work that we're doing right now.
Okay, Lori Doyle.
Thank you, Madam Chair, members of the committee. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland. It's really a pleasure to see all of you today. We are in support of this bill. It seems like another lifetime when you all in the General Assembly passed two bills in 2018 and 2019 that gave us the opportunity to allow our ACT team prescribers to provide their services via telehealth. And it was done really in response to the prescriber shortage here in Maryland and to make most efficient use of that scarce resource. And we thank you for that support at the time. As Delegate Kelly said, ACT teams serve some of our most challenging individuals. And so before you passed that legislation, we had prescribers driving around sometimes for hours trying to locate these very individuals that they were trying to provide services to. It was a very inefficient use of their time. Of course, back then, telehealth was not used that often. And so a sunset was put on the bill to make sure we weren't going to break the bank. And then COVID came along and everyone's world changed. So now that COVID has introduced telehealth, not only introduced, it's become the preferred modality in many regards. We have 3 years worth of data since that time to show what's happened with our ACT teams. And what we have found is that there has been no increase in the cost. In fact, that's reflected by the Department of Health in the fiscal note. And so the sunset on this bill runs out September 30th of this year. So if we don't act now, there will be a gap before you meet again in 2022. So we ask that you allow us to keep our good work going and remove this sunset and allow this bill to take effect on July 1. Thank you so very much.
Thank you very much. Next, we'll hear from Susan Blumberg.
Susan is not with us right now. I just resent her the link,
Oh,
but
okay.
Keep our good work going.
We'll go to Lynn Davis.
Allow this bill to take
I
effect
see
in
you
July
there,
1.
but someone
Thank you
needs
very
to
much.
mute her mic or his mic.
Either way.
Thank you, whoever that is. Lynn, you need to unmute. I have trouble with it too. While she's doing that, let me say that I apologize to my staff. I found the note. I just needed to know where to look for the note. Thank you. You there, but someone needs to mute her mic. Lynn, mic. Thank you, whoever that is.
Okay. Thank
Lynn,
you. Yes.
you need to unmute.
Oh.
No, she's unmuted. I have trouble with it too. While she's doing that, let me say that I apologize to my staff. I found what we're hearing is the lag time, and you're listening to it on YouTube. Can you turn your YouTube off for now? Thank you, whoever that is. Because we're hearing the simulcast.
Yes.
You need to unmute. No,
Okay.
she's unmuted. I have trouble with it too.
Yeah.
Lynn, I believe we're hearing are you following this on YouTube, Lynn? What we're hearing is the lag time.
Yes, I may be.
Can you turn your YouTube? Could you turn that off, please? Close the window that YouTube is running in, please.
Okay. Sorry, I think I've done that.
I think you have. It sounds much better now.
I'm so sorry.
That's okay. These things are happening to all of us. It's a new
Okay.
world.
Thank you. Good afternoon, Chair Pendergrass, Delegate Kelly, and honorable members of the committee. I thank you for this opportunity. I'm Lynn Davis, the Executive Director of the Carroll County Youth Service Bureau. We're an outpatient mental health clinic serving all ages of people with substance use and mental health concerns. One of our programs is Assertive Community Treatment, or ACT. We currently serve about 92 adults who have a very serious lifelong mental illness. While 100% of our ACT care management services remain in the community face-to-face, we began using telehealth for some of our psychiatric appointments. Telehealth has been the single most important strategy that has kept our ACT clients connected to their psychiatric care and medications. And for these folks, medications are often a very critical component of their care, of their stabilization, and their progress. During this time, we are discovering that psychiatric telehealth has its significant advantages for some of our ACT clients long-term. To name a few, Carroll County is a rural community, and the distance to clients' homes is 30 minutes to 80 minutes round trip. These are taken by our psychiatric providers who travels to patients' homes, or double that for the staff member who goes out, picks up the client, brings them to an appointment, and then returns them back home. Secondly, we are experiencing many fewer cancellations from our patients. Virtually no no-shows. People are there when the telehealth happens. And this increases our continuity of care. If a client cancels an appointment, it is so easy just to reschedule that appointment for the same time, for the same week, which is unheard of when we do face-to-face appointments. Also, if a client is having a medical emergency or just a medical illness that they don't feel well enough to travel to the agency, often they're okay to take a telehealth visit, knowing that their medication will be refilled and that all the help that they've been receiving is going forward. And please know that we use audio only on a very minimal basis when face-to-face and when computer access is not available. So I respectfully request that you give House Bill 191 a favorable report. Thank you.
Thank you. Delegate Cullison, you appear to have a question? Or is that the previous?
I'll wait for the panel to be done. I just was raising my hand because I already had my question.
I think that the panel is done.
Oh, okay, then
That's
yes.
how many witnesses we had.
Okay, then I.
Thank you. I'm
So-
sorry.
We actually have one more witness. Sue Ann was able to join us. Sue Ann.
Oh, well, we'll go back to Sue Ann. Great. And then we'll do the question. Thank you. Sue Ann Blumberg, are you there? Ready to go?
I am here. Let me turn on my camera. Boy, I've had a heck of a time. Okay, I should be, can you hear me? You may not be.
We can see and hear you. You're great. And we're all having a heck of a time, so don't feel bad.
Oh my goodness, I'm telling you. So thank you, Chairperson Pendergrass and the committee. I really appreciate you giving us time to hear House Bill 191. An ACT team, we have an ACT team. The ACT team is a group of professionals that go out into the community and they get some of our most vulnerable and in need citizens in our communities. And it is something that is remarkable work when you see it happening. So us being able to use telehealth, our prescribers in particular, and I did put in my testimony, but I myself was very pleased with the data. The 6 months prior to this bill being in place, and then I measured the 6 months after this bill was in place, and our prescriber in our ACT team was able to see 200 more client appointments than he was prior. What that means is less ER visits, less hospitalizations, and much better care for our clients. Our clients have told us all that they much prefer being able to utilize telehealth if they need it, and they feel better served by having that as an option in our arsenal of tools that we use with some of our most needy people in our communities. So I ask for a favorable report and that you support this bill, and thank you very much.
Thank you. Now we're going to turn to Delegate Cullison.
Thank you, Madam Chair, and thank you, Delegate Kelly and panel for this bill. As you know, we're going to be considering a number of telehealth bills, and I want to make sure that another bill won't cover the need for this one, that this one is specific to the ACT, the ability of the ACT teams to use telehealth. It's not like if we pass an omnibus telehealth bill, the needs of this bill would be met, right or wrong?
Thank you for that question, Delegate Wilson. We need to do this bill in order to lift the sunset. So that's why this bill is sort of a standalone bill and sort of being discussed separately from the omnibus other important telehealth bill.
Oh, thank you very much.
I see no other hands. I have a request of Ms. Blumberg. I was pleased that you talked a little bit about data. You had the data that you're seeing more clients.
Yes.
It would also be very helpful if we had the data to know how many people, what the hospitalization rate and emergency room rates were with your clients. If you could look and see if there's any change in that same period.
Sure.
That would be incredibly helpful.
Absolutely, we can do that. And
Thank
I will
you.
send that to you, Madam Chair, so you can disseminate it to the committee.
And absolutely, that's exactly what we'll do. Thank you very, very much. We appreciate your testimony. Are there other questions? I see no other hands. So I'm going to say thank you to the sponsor and the panel. And that ends the hearing on House Bill 191. And we will now move on to House Bill 123. And that is Delegate Pena-Melnick. What a nice number you got. Delegate Pena-Melnick, are you there? Well, that's odd. Do you see her in the list, Melissa?
I am not seeing her on the list. Give me 1 second.
Well, I'll tell you what we're going to do. We're going to give you a 5-minute break, which is to say you don't have to sign out or sign in. You can turn your camera off if you like. Give us all a chance to do what we need to do. I am going to phone her unless she's popped on. I don't see her still. I will see if we can find out where she is and get her here. So we'll put the, I don't know if we have a break thing. I think we do, but you don't have to do anything, members, if you don't want to, and I'll see you back. It's 2:36. I'll see you back at 2:41. Okay? Thank you. And thank you for your patience, everyone.
Chairman, she's on another bill. You got on mute.
Is she in another committee?
I believe so.
Okay, that's why we put this bill last, isn't it? That's
Yep.
the problem. So here's what we're gonna, are we televised now talking to each other?
Yes.
Okay, well, that's fine. Let me look at the sign up sheet and see who we can have present, because we need to have the bill. Are you text, did you text her to see? Yes.
I'm sorry to interrupt. She says, start with the Maryland Hospital Association.
Okay, we'll let them present the bill. That's fine. Thank you for that. We'll be back at 2:41, and the Maryland Hospital Association will have them start. Who is on from there? I'm looking for them.
Chair Pendergrass, this is Monty
Mancy
Ross. Yes, and I'll be happy to present the bill.
Okay, so will you present the bill? Do you feel comfortable doing that?
Sure.
Excellent.
Thank
When the group comes back, that's what we'll have you do. And if Delegate Peña-Melnick returns, we'll let her have a chance to speak. But
Sounds good.
Thank you. It's never a dull moment in this system. Staff, you want to put us back online? Great. Are most of us back?
Chair, this is Susan Krebs. I just texted Melissa. It doesn't appear that there's any testimony uploaded for House Bill 123. And there's a lot of it on the list, but we can't find it in the system.
Yeah, it's a thick folder. I don't know what went wrong. We'll see if we can straighten it out. First, let me say thank you, Delegate Krebs, for bringing that to my attention because I'm not aware of it. I don't know how we were able to print it out if it wasn't uploaded in there. It's making no sense to me, but that
Madam
doesn't
Chair?
mean anything. Yes.
I have it on my system.
Okay, well, I'll have to look at it. There's no little box there to pull it down from. I'll check on a different computer. It's the only
Okay.
thing else we got for the whole day except that.
I would love to be able to tell you that I knew how to fix these things, and I don't. All I can tell you is, why don't you try to find it with your staff, and if that doesn't work, get in touch with IT because they're the experts. My staff is not the experts. We go to
So it is
IT when
there.
we need.
It's
somebody-
there. I found it on mine also. If you just pull up the bill and you can find it under the testimony tab.
Okay, so we didn't have, the testimony tab wasn't there, but we will try again. Thank you.
Okay, again, if anybody has problems with tech stuff, let's go to IT for the answers because we're not that good. I'm glad we were able to get the YouTube turned off so that we could hear what that witness was saying, but that's about the level we can deal with. As in, if it's got to be done right this minute, it's got to be done. With that, Delegate Pena Melnick, we put this bill last because she's in another committee on a bill. And so unfortunately, we were very efficient today, fortunately, actually, and we're at this point. So what we're going to do is we're going to ask Mansi Raswani if she would please explain the bill and act as Delegate Pena Melnick for now, although we may give her a bite at the apple at some point. If you would start, please.
Absolutely. Thank you, Chair Pendergrass. I'll do my best, that's for sure. Thank you. For the record, Mansi Raswant, Vice President of Policy, representing the Maryland Hospital Association and our 60 hospitals and health system members.
Hang on a minute. You have 5 minutes. You're presenting.
Thank you.
So let's yeah, you don't have to talk so fast.
So I do want to thank the Vice Chair. I realize she's not on, but appreciate her commitment to improving access to healthcare and this committee's commitment to improving access to health. Just yesterday, you heard several bills, important bills related to health disparities that were introduced by the Vice Chair. And I want to note that like so many other issues, COVID has really elucidated the stark gaps in access to care and health disparities. But we know that there's one tool that's been historically very underused, but it's more than proven its benefits to close those gaps, and that is telehealth. And this is true for particularly the most vulnerable populations. You may have heard that the silver lining to the COVID-19 pandemic has been this promise of telehealth that we've been able to see. And that's really because insurers have worked with providers to quickly ramp up coverage for those services so that providers could scale services and really meet patient needs during the pandemic. So telehealth is being used across the state, from Western Maryland to Baltimore City to the Eastern Shore, to ensure continuity of care for patients that have asthma, diabetes, cardiac conditions, behavioral health conditions. And while we know that this current crisis is temporary, the research shows that the use of telehealth is not. Care patterns are permanently changing to incorporate telehealth as patients are able to access care without those traditional barriers of transportation or childcare. And providers are also seeing the benefits in ways of improved health outcomes, such as patient satisfaction and engagement. But robust access and continued access in this space, and in fact, the uptake and use of telehealth, is premised on comprehensive coverage and sustainable reimbursement. So we really need this legislation to ensure that Maryland does not go back and that these benefits are not time limited by the public health emergency that we're under. This bill allows for providers to meet patients where they are by removing arbitrary requirements that patients have to be in a clinic to receive telehealth services. It also enables appropriate use of audio-only services, which particularly in the recent months have been sometimes the only way that providers can could provide care, to patients. It sets out a framework for fair and adequate reimbursement to providers for their time and expertise. And it expands tools that remotely monitor an individual's condition, allowing providers to understand that in more real time and adjust treatment as needed. So you heard a little bit of what the bill does. Let me tell you what it does not do. The bill does not change any standards of care or make any changes to scope or practice for providers. It does not change any clinical judgment that providers use to determine when it's best to use audiovisual modality or audio-only services, or when that patient really needs to come in for in-person care. It also does not remove any of the normal methods that insurers have to review claims and process claims in this space. It simply works to ensure that providers and consumers have the ability to use telehealth so that consumers can be able to best access care. And I don't really have to go on about that, although I recognize I've got a little bit more time to do so, but you are going to hear from providers and from patients directly on this. These are real people, and your favorable report on this bill is going to have an immediate impact to ensure that many providers and many patients are able to receive and deliver the most appropriate care and the best care possible. So with that, I'll stop and I'll ask for a favorable report on House Bill 123.
Thank you. I'm going through the list in order that there is, but if you have a different plan, those people in favor, I can reorder them if someone lets me know. I have Katie Kaufman next. Katie, are you there?
I'm here.
Excellent.
Good afternoon, Madam Chair and committee. My name is Katie Kaufman. I'm a Baltimore area resident, and I'm here today to tell you how my family and I are in support of House Bill 123, Preserve Telehealth Access Act of 2020, and encourage you to vote in favor. As a parent, I've long been grateful for the opportunity to talk on the phone in the middle of the night with a pediatrician from the comfort of our home. And during the pandemic, I've learned just how much more is possible virtually in the care of my entire family. For better or for worse, over the past year, every member of my family and I have used and benefited from telehealth. Our visits have included video and audio visits with primary care physicians, endocrinologists, physical therapists, psychotherapists, orthopedic surgeons, and cardiologists. And in fact, my husband is a recovering COVID patient in the other room on the phone, telehealthing with his cardiologist at this very moment. So that's why I'm a little out of breath running from the other room to be there to talk about his health with him. My son's physical therapy for foot surgery recovery transitioned to virtual visits in March, and his physical therapist had my son jumping, running, twisting, turning around in our living room, and all the while easily laughing and relating as they did, just like they did in the office. His therapist was also able to see my son do his at-home exercises at home, checking his form with using a particular chair over another, for example. And all of the doctors we've worked with have really thoughtfully determined whether an in-person appointment would be necessary or when telehealth is an option. And they've asked certain questions. We've discussed this, and to make sure that we get the most appropriate care. Without telehealth, our family would have been forced to choose between two negatives, exposing them to additional risk for COVID, or going without the medical advice and treatment we knew we needed. So thankfully, we didn't put ourselves in that situation, and we availed ourselves very liberally with the telehealth option. So we've seen during this crisis that we don't have to do things the same way. And we do hope to continue to have access to telehealth after the pandemic is over. Thank you again for your attention and for your commitment to ensuring Marylanders continue to have access to telehealth, including audio-only options. And my family respectfully asks you to pass this legislation.
Thank you for your testimony. We'll hear from Brian Hasselfeld next.
Great. Thank you. Good afternoon, Chair Pendergrass and members of the committee. Thank you for this opportunity, and thank you to Vice Chair Pena-Melnick for introducing this important legislation. My name is Dr. Brian Hasselfeld, and I'm the Medical Director for Digital Health and Telemedicine at Johns Hopkins. And I practice internal medicine and pediatric primary care here in Baltimore City, seeing patients of all ages. Johns Hopkins is pleased to support HB 123. Telemedicine is a tool for providers of all types and specialties that has been critical to meet our core aim in healthcare, the right kind of care to the right patient at the right place and the right time. In every patient at every age, there are some medical issues that are not only adequately dealt with by telemedicine, but in many instances better dealt with via telemedicine. In my pediatric patients with poorly controlled asthma, the ability to evaluate for home triggers such as pets and carpet is much improved via telemedicine. And in my adult patients on multiple medications, no longer can they say, I forgot my medications at home. I can see all these issues in real time in the modern virtual home visit. Giving clinicians the ability to choose the clinically appropriate tool, including the choice between in-person and telemedicine care, has enhanced my ability to care for my patients. We've done almost 750,000 telemedicine visits and collected 62,000 patient surveys. Patients want telemedicine care and are speaking loudly, rating their providers 95 out of 100 in their telemedicine visits, and 9 out of 10 has stated they would continue telemedicine and recommend it to friends and family after the pandemic. Lastly, our internal team works off of a mantra that telemedicine done well may address healthcare disparities, but if not, may exacerbate them. Use of audio only is not evenly distributed. Our patients insured through Medicare and Medicaid use audio only up to 30% of the time, and these numbers have only marginally improved. Further information is available in my written testimony. Audio only is about equity of access to healthcare. Thank you again for the opportunity to speak with the committee, and Johns Hopkins urges a favorable report on HB 123.
Thank you for your testimony. We'll now hear from Rosalind Berkowitz. Oh, I'm sorry, she's not on the list. She is not in the panel. Rachel Gonzalez.
Hi, everybody. Can you hear me?
Mm-hmm.
Okay, great. So good afternoon, everybody. I am a therapist and a case manager at Healthcare for the Homeless in Baltimore City. Through this past year, like all of us, I've learned a lot about telehealth. I think particularly the audio-only version of telehealth. I do have a story I'd really like to share with you guys that I think highlights the value. I work with a client. She's a young woman. At the time of this incident, she was about 7.5 months pregnant. She called me one day saying she was at the hospital. She had presented for standard prenatal checkup, was heavily bleeding, and was told that it was likely a placental abruption, which could be fatal to both her and her child. She was having a really hard time coping. She was very stressed, very scared, very panicked, and had actually attempted to leave the hospital to come see me at the clinic for support. And so because of our ability to offer the audio only telehealth right now, I was able to tell her to stay where she was, to stay with the providers, to keep herself and her baby safe. And I was still able to offer the support that she needed over the phone. So I think, like many of our clients at Healthcare for the Homeless, a smartphone, tablet, internet access, all of those types of things are just a huge barrier to the audiovisual telehealth. I couldn't imagine asking her to hang up and then find a different means to reconnect with me through an audiovisual platform. I think COVID has done an incredible job of highlighting just about every inequality in our society, healthcare access being at the top of the list. I hope that we can let part of COVID's legacy be a lesson learned about accessibility and humanity, and do everything that we can to make healthcare accessible to everyone, including in-person, audiovisual, and audio-only telehealth. I would ask you to consider if my testimony today would be any less valid if I had simply called over the phone as opposed to joining via Zoom. Thank you.
Thank you very much. With that, we will move to Ben Steffen. Are you there, Ben Steffen?
I'm here now. Chair
Thank you.
Chair Pendergrass, members of the committee, Ben Steffen, Executive Director of the Maryland Healthcare Commission. Thank you very much for allowing me to speak today. We're here to support House Bill 123 with some compromise amendments. As many of you know, for more than a decade, Maryland Healthcare Commission has been wandering in the wilderness, being one of the prime organizations in state government to promote the adoption of telehealth. It's been slow going, but as a result of the COVID-19 public health emergency, we've seen a flood of adoption over the last 8 months, adoption that we applaud and have worked hard to further. The Healthcare Commission has engaged with small providers in furthering adoption. And we think our record for supporting this technology is equal to none. Here today, though, we think that it's also important to think about what is the best way forward. We are still in the midst of the pandemic. We're looking at what should exist as the standard of care returns to a normal situation. We think that it is appropriate to consider the input from both providers as well as payers. We've offered 8 amendments, not as daunting as it may seem because of the nature of the bill. It covers both the health general and insurance statutes. So amendments 1 through 3 and 4 through 6 are basically the same, but apply to different articles. And they would basically focus on addressing some of the issues that we think are most controversial, including parity and adoption of audio-only features. We are here to support healthcare providers and payers, and hopefully we can fashion a compromise that's workable to all. Thank you very much.
Thank you. And I want to say to you, I know how hard you've worked on this, and also David Sharp, I believe, has done a lot of work. You had a 70-member stakeholder group working on this. I'm very grateful for all the efforts you put into it. Without your efforts, we would have had a much harder time getting to where we are today. With that, let's move to Allison Taylor. But don't leave, there will be questions probably.
Hey, can you guys hear me? I can't, okay,
Yes,
there
ma'am.
I am. I can see myself now. Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Telehealth, so I want to talk to you a little bit about what telehealth has meant to our health system over the past several months. We made a big investment in telehealth in 2013, which helped us when the pandemic hit to make a pretty quick transition to doing a lot of care, a lot of virtual care. Before the pandemic started, we were doing about 15% of our total care through telehealth. And in the few months after that, we were going up to about 90% total virtual care. Now we've gone down to about 50% still, but I included in my testimony a chart that shows kind of the levels of telehealth that we have experienced over the past several months, in case that's of interest to the committee. Of the 50% of telehealth that we're currently doing, about half of that is audio only and half of that is like through video. And that, going back to my point about having made a big technology investment at an earlier point, this need for audio only really is driven by patient need. We have our Medicaid patients, some of our older patients are less able to use video. Either they don't have broadband or they're not comfortable with the technology. So our reliance on that has been totally driven by our members. So for that reason, it's critical to us going forward that continue to be available. One kind of cool thing that's come out of all this is our members, we've seen huge increase in member satisfaction from having more telehealth opportunities available to them, which maybe you wouldn't have expected to see in a huge health crisis like we're in. So based on that, we're looking to really make telehealth an important piece of what we do going forward, and appreciate the committee's work on this issue and the sponsors' leadership. We've been working with Mr. Stefan and all the parties here around some amendments, and happy to continue to do that. And thanks for having me.
Thank you. Deb Rifkin.
Hello, Madam Chair, members of the committee. For the record, I'm Debbie Rivkin, Vice President, Government Affairs for Care First Blue Cross Blue Shield. First time to be before you. Hopefully, I'm not technology challenged like I usually am, and you can hear me and see me. We are here today, Care First is here to support this bill with amendment. I want to start off by saying, please make sure you understand we have had a telehealth law for the past 9 years on the books, and telehealth has been reimbursed by carriers for services that are able to be performed by telehealth consistent with what they would be done in an office. So telehealth is not going away when the pandemic goes away. It's still the law in the state of Maryland. Now, there may be some adjustments that you all want to make to the law. We have been talking with all the stakeholders and the sponsors on this. I will say that we've had numerous meetings on this topic. We are learning more internally at our company. And in the spirit of compromise, Care First did support the Healthcare Commission's amendments because it does three things. It created a short-term solution. So we have something in place now that goes beyond what the state law is, if that's where the decision of this body. It creates a study so we can figure out what's appropriate in the future. So we'll look at things like what are the impacts to cost, quality, access, and outcomes. And it also creates a sunset. So at the time when the study is done, we can discuss what are the results and what are the best next steps going forward. So we could have a very careful discussion of what steps need to be going forward beyond what the law is today. So with that, we will continue to discuss with all the interested parties and work towards a fair compromise. Thank you very much.
Thank you very much. And we appreciate that all sides have participated in this and they're trying to get to where we need to get. At some point, we'll find the balance, and if it's imperfect, there's always another year to tweak it, but we do need to make some changes at this point in technology, frankly. And the last witness, except for Delegate Pena-Melnick, who will get 2 minutes since someone else did her 5-minute job for her, will be Winnie Moore. And we'll let Delegate Pena-Melnick wrap up.
Good afternoon, Madam Chair and committee members. The Board of Professional Counselors and Therapists do not oppose the extension of telehealth. The board opposes the use of telehealth utilizing audio only in House Bill 123. A lot of what we do in evaluating for mental health disorders and substance abuse disorders is nonverbal. Providers need to be able to observe nonverbal behaviors to effectively treat clients. With audio use only, the provider cannot observe a client's eyes or mouth moving slowly, red eyes swaying, or lack of coordination. The nonverbal indicators or cues could go undetected, specifically by an addictions counselor. As a result, there is an increased chance of a misdiagnosis. The provider is unable to observe psychopathic features of the client. With audio only, providers cannot assess the client's orientation. A provider cannot evaluate facial expressions, movements, attire, or personal maintenance, body movements, and hand gestures. These are just some examples of nonverbal cues that are instrumental in diagnosing mental health. A provider is unable to identify the client by using only audio. In audio and video telehealth sessions, the provider can verify a client's identity by the client's driver's license. For these reasons, the Maryland Board of Professional Counselors and Therapists opposes the use of audio-only telehealth. Thank you for your consideration.
Thank you very much for bringing that to our attention. Matt Celentano, you're next. I got things out of order, but that's not unusual for me.
Thank you, Chair Pendergrass. I wanted to have an opportunity to speak, and I appreciate you calling on me. Matt Celentano here today on behalf of the League of Life and Health Insurers, forward with amendment on House Bill 123. As you know, carriers have voluntarily expanded telehealth coverage early in the pandemic to meet unbelievable needs. We suspended cost sharing, and nobody has backed off nor will back up in the midst of the public health emergency. The carriers have been consistently involved in these telehealth policy discussions through the summer, through 5 MHCC work groups, briefings before this committee and others. We've had endless conversations with the MIA about coverage to meet the needs of a crisis. Many stakeholder meetings, including with the sponsors, and a stakeholder meeting last night with the MHCC. We are going to stay at the table to find a solution that works for Maryland. Our 3 concerns as of now is that we're going to make wide sweeping changes to something that we can already do that's been on the books since 2012 in the midst of a crisis. We have no line of sight during the crisis. It would be appropriate to go with the study that the MHCC is advocating for, because we need to see the data utilization prior to the pandemic, during the crisis in which we are still in. 50 out of the last 60 days, we've had 2,000 or more daily infections. And then we need to see how it normalizes when it goes back to figure out what is the best use of how we address these concerns. We need data before, during, and after. There are lots of outcomes that we know that will be better in person. There are a lot of outcomes we might find out that are going to be best served by doing audio only. But we're not going to know unless we take a look at the entire marketplace. Our concern on acting too quickly is we won't have the benefit of the information and the experience. That being said, we have just to remember that we don't treat telehealth as a monolith. It is completely separated by different kinds of procedures and different kinds of coverage. And we will continue to stay at the table to come out with a good product. Thank you very much.
Thank you very much. There will be questions, but before we do that, I'd like to go back to Delegate Pena-Melnick and give you 2 minutes to say a few words. I know that the bill has been presented.
And thank you, Madam Chairman and members of the committee. I'm sorry I was in another committee, but I am okay, because the witnesses you had, we have been working for months on this bill and holding lots of meetings. So I want to thank everyone for being at the table and for staying at the table. And I want to thank Senator Griffith, who's leading the bill in the Senate. You know, access to healthcare services has been a long-standing issue, and we know in this committee, which has become even more significant with the pandemic. Maintaining and expanding access to care through telehealth will reduce the barriers that exacerbate health disparities that we're seeing in Maryland. And House Bill 123, as amended, the audio-only telehealth services are very crucial in this bill. And they're crucial because we know that older adults and low-income families are less likely to have access to smartphone, webcam, and a broadband internet, and therefore may not be able to have video telehealth meetings with providers. Over 300,000 Marylanders living in rural areas do not have access to consistent broadband internet. Audio-only services allow us to bridge that digital divide. This is just another tool in the toolbox. We're not saying that this is the only one, but we are saying this is an important one and that we should maintain, as we go through our daily lives. Also, the bill ensures the continued availability of Maryland medical recipients to receive telehealth care in the sites where they are located. As you know, it's very difficult to travel right now. So we know that even with a vaccine, social distances will need to persist for months to come. By enacting this bill, we would ensure continued relationships between patients and providers, all while preparing Maryland to face future crises that will require patients to interact with their providers virtually when it's not safe to do so in person. I would ask respectfully for a favorable report. Thank you.
Thank you, Delegate Pena-Melnick. Now let me look and see who has questions. We'll start with Delegate Lewis.
Thank you, Madam Chair. Thank you, Madam Vice Chair, for bringing this great bill, and to all the panelists. My question is specifically for Ms. Moore, who expressed concerns on behalf of the licensed therapists regarding audio-only telehealth. And I was just wondering if you could clarify a little bit, is it a blanket opposition to audio-only services, or is it a concern about using audio just for the preliminary intake, that initial visit where assessments are typically done?
Yes, ma'am. Primarily for the diagnostic assessment, and that the first and maybe second time that we see a client, and ongoing for substance abuse, because we know that the possibility for relapses and things. So we'll need to see the client. So not in general, we're opposing, just specifically for certain things like behavioral health and substance abuse.
Okay, thank you for that clarification, Madam Chair.
Thank you. Delegate Hill.
Madam Chair, I think my question was answered.
Okay. Delegate Cullison.
Thank you, Madam Chair. And in the spirit of equity, I'd like to ask Dr. Bryan a question. So I heard you say a couple of things about this being a choice, and that the provider, it's just an additional tool for the providers. So I want to talk about from the consumer perspective for a second. Would the consumer under this bill have choices about the kind of tool that they want to use, and whether they want in-person or telehealth? And how is the consumer guaranteed the same level of service standards, scope of practice in the virtual world as compared to in-person?
Yeah, I think it's a good question. I appreciate it, Delegate. There's a couple of things there that are definitively operational and outside the scope of the bill. I think it's important, though, to clarify that nothing about this bill changes scope of practice. And I'll just speak personally as both a provider that cares for both children and adults on a data. I'm in clinic today, actually, and have a telemedicine visit coming up right after this session. As a clinician, I always need to choose the right type of care to diagnose and treat. That's my scope of practice. And if I find that a patient comes to me in person and needs emergency care inside of my scope of practice, I need to send them to the emergency room. On the flip side, if a patient comes to me in person and I recommend that the next visit be done via telemedicine, as my last visit is today, because we're following up on home blood pressure, that's also within my scope of practice. It's the clinically indicated tool on a patient-to-patient basis and on a disease-to-disease basis that is difficult to decide ahead of time, but is decided by me, the clinician, in discussion with my patient. If a patient chooses to access me through telemedicine for an indication that needs further care in some other venue, that's always a possibility. And it's not my obligation to treat someone inappropriately through a modality in the same way that I don't deliver emergency care in my clinic. So I think that the scenarios are wide and varied. It's important that the bill does not expand or change any provider scope of practice in the state, but rather puts it in the hands of clinicians and patients to recognize that in-office care wasn't the standard 100 years ago. In-home care was. In many ways, this brings us closer to the previous standard of care and gives both parties a choice, which I think is critical.
Thank you. Thank you, Madam Chair.
Thank you. Delegate Rosenberg.
Thank you, Madam Chair. My question goes to the bill's sponsor, Delegate Peña-Melnick. I know you weren't here for much of the hearing, but you've been working on this bill for quite some time. Can you speak generally to the amendments that have been offered and the process you've gone through over the summer?
Yeah, the amendments, one second, please, were the ones that Ben Stephan, did he testify? I'm sorry, I wasn't here.
Yes, he did.
He did.
Yeah, did he discuss the amendments?
Not specifically, no.
Okay, one second. I apologize. Give me a minute.
I think that's accurate. I think I was paying enough attention. Is that correct, Ben? Okay.
Yeah.
Would you like me to ask another question or have someone else in there get back to you?
Yeah, I'm
That's
I'm
fine.
looking for my binder.
We'll come back to that. Delegate Bandera, you're next on the list. We'll come back, Delegate Rosenberg, I promise.
Yeah, thank you. Thank you, Madam Chair, and thank you, Vice Chair, for this wonderful bill. Absolutely, this has been our norm, this telehealth, but I would like to listen from stakeholder, basically from hospital, what are the challenges on regulation, adoption, technology, evidence, and success? So I would like to know the challenges, how we are doing. Are we investing enough in technology and evidence and regulation? What are the challenges? How we can help you guys?
Sure.
Would Mansi Raswani like to answer?
Absolutely, Chair, and thank you, Delegate Mandari, for that question. Really appreciate it. I think when you're speaking to the challenges, a large part of the challenge pre-COVID, if you will, was just ensuring that we had the right type of coverage in this space. So I think we've heard that we've had coverage on the books, but if we don't have sustainable reimbursement with that coverage, it's hard to invest in the technologies to really scale up the technology that you need to be able to deploy telehealth as accurately and as best as possible to meet the patient needs. So that's been a significant challenge. And I think that's why we have this bill in front of you, recognizing the promise that we've seen through telehealth when we've had some of these coverages put in place and some of the waivers really peeling back some of the restrictions. The other thing I would want to add in this space is from a regulatory standpoint. I think we have a lot of that regulatory construct in place right now. We've got waivers in place that are trying to, again, peel that back. And then this bill will, at the state level, ensure that we have more of the waivers that have been put in place, some of that, the promise that we've seen through it continue post the pandemic. And so I would say, in a nutshell, the challenges that have really existed is knowing that we had the right type of coverage structure to be able to invest in the technologies. And that's why we have this bill in front of you, to be able to make sure that we can really secure those investments.
Thank you.
So I am back.
Are you ready?
Yes, sorry, there are a lot of them. Okay. So yes. There was so one of the amendments that we have was the definition of healthcare practitioner. In the Health General article, the bill defines a healthcare practitioner who can perform the services of someone licensed or certified under the health occupations article. And then the current law of the insurance article limits the scope of who may pay for telehealth services to licensed healthcare providers. This provision is unchanged in this bill and could lead to those providers who can have certifications to not being paid by the carrier. So we did build consensus against, for that amendment. So people agree to accept that. Where we're under review is where it says service provider by Medicaid. It says here, Kaiser Permanente supports the changes to this section that remove the originating site requirement from all healthcare services in the Medicaid program. That's still under review. We have also dealing with the definition of healthcare practitioner. That's also under review. The audio only is also under review. The reimbursement, we also are under review. So in the section 15-141.3, audio only conversation means a discussion between a healthcare provider and a patient that does not result in delivery of billable healthcare services, which is conducted using audio only technology. And then audio only health services means the delivery of billable health services that is delivered by a licensed healthcare provider within the scope of practice of the healthcare provider at a location other than the location of the patient using the audio only technology. So basically, to the extent authorized by federal law or regulation, coverage of and reimbursement for healthcare services delivered through audio only technology shall apply to the program and managed care organization. So this is under review because the Maryland Hospital Association feels a certain way and the MHCC amendment, is very different. So we basically, and we have a couple more that we're working on, Delegate, which is why I needed to read it because there's so many, but we are at the table and we are in discussion. Ben Steffen, has been great. He submitted some amendments. The hospital has them. I've been in communication with, Care First, as well as Kaiser, and what we're planning on doing. And I spoke and met with the actually the sponsor of the bill in the Senate, Senator Griffith. I met with her yesterday. Is that immediately after this bill hearing, and they had their bill hearing actually earlier, 1 o'clock today, that we would call a meeting and bring everyone back to the table to see where, we can just compromise on all these amendments. I mean, I have here about 5 pages of, different amendments that some we have built consensus and some we have not, but where we're stuck is with the audio only definition and with the reimbursement part of it is where we're stuck. So we need to unstuck ourselves and try to find a compromise, and I will give it my absolute best.
And at some point in the near future, we will be moving this bill to subcommittee, and the things that are left unresolved will become resolved by us, as opposed to sitting around the table in the same way that you are. So I'm encouraging everybody to try to get to yes.
Thank you.
You're welcome. I see no one else except me who has a question. My question, I think, is for Matt Celentano. My question is, you talk about having data, and that is a really good plan. It helps us to make decisions that are best for everyone, both the providers and the payers, but most of all the patients. I'm wondering what kind of data you expect to be collecting, because you have information from what you're paying. Is there other data that is going to need to be collected? And do we need to do anything about data collection in the bill, or is there something that addresses that?
Thank you, Chair Pendergrass, for asking. I think this is more of a broad sort of point that we were discussing. I mean, we have claims data, obviously, and it would all go through the Maryland Healthcare Commission. But what we have seen since really March of last year is an explosion of utilization that we hadn't seen ever before. We were going from somewhere in the neighborhood of 12 to 15% of visits being telehealth to somewhere in the neighborhood of 90% in a matter of weeks. We are still seeing really, really high levels of telehealth utilization. What our sort of point was is to establish the world and what we should be looking at and what we should be addressing through legislation is it would be important for us to see a snapshot of prior pandemic utilization in all the specialties. During the pandemic, when the explosion happened, where we really saw telehealth being utilized like it had never been before. And then after, when it gets back to levels after the pandemic, when all of our lives get back to normal and we're not doing this on a computer and in person. I think that's sort of important. There are a lot of people that believe that we are going to go back to sort of prior pandemic levels. It will never go back as low as it will because of the expansion of the use and the comfortability of consumers with it. But there are a lot of folks in the carrier community that are speculating it will be higher, but not that much higher, because people still want to see their doctor for the most case. There are some instances where audio only has been especially useful, and that might be in the behavioral health space, or it might be in rural areas where there isn't the ability to do video. So there is definitely a place to have a conversation about expanding the use of telehealth, but to try to use it as a one-size-fits-all without seeing the entire experience, we think is a little unwise.
Can you hear me?
Good. Muffled. We can hear you.
Bad news is, guess what died in the middle of your explanation? I can't get my volume back on, believe it or not. I think that I've tried pretty much everything, and so I think I'm going to turn the rest of the meeting over to Delegate Penny Melnick. I think we're done. We're through our list. We're through our questions. But I want you, Delegate Penny Melnick, to make sure that's true. And if there's something that needs to be said, you can hear and you can end the hearing and the meeting if that's where we are, please.
Yes, I believe that we're done. I don't think we have any more witnesses. I know that, to Mr. Santillano's point, hospitals and Kaiser have plenty of data that they share anytime. So we will continue to talk and try to work on the 2 outstanding issues, which are, looking at Ben Steffen's amendment, looking at the audio only definition and the reimbursement issue. So you can expect basically, you can expect a call from my office and from the senator's office. Okay. Melissa, can you confirm that we're done with the witnesses?
Yep, we've finished all the witnesses for this.
Yes, so this will conclude our bill hearing today on House Bill 123. Thank you so much, and I hope you have an amazing